This is actually our record attendance at the webinars. We've been going for a few years now. So that's great to see the interest in this webinar. Whilst everyone's here, Sarah, our Executive Officer, has reminded me to encourage those of you who may not be members of the association and the work that we're doing. And I guess I'd just highlight that with the Medical Research Future Fund and those funds starting to flow, it's really quite an important time for health services research. So it'd be great to get all of those of you who aren't involved in the association, and Sarah will be contacting you with emails after the webinar. But today we're focusing on Trish. So we've got Trish Greenhalgh, who's on a tour of Australia, who's kindly agreed to provide this to present this webinar today. And some of you may have been following Trish's exploits via Twitter, and we've, prior to the webinar, agreed that the hashtag #TrishOnTour would be an appropriate hashtag to use for anyone who wants to make comments on Twitter about the webinar during or after. So #TrishOnTour, all one word, would be the hashtag. So Trish is actually, I meant to ask you, Trish, you've got an unusual background in the sense that you did a degree in social and political sciences followed by a medical degree, and was that planned, or did you?
Well, actually my first degree is technically in social and political sciences, but actually it was an intercalated degree. So I started off doing medicine and then did a bit of what they called SPS at Cambridge, and then continued with my medical course. And yeah, I think about 10 of us in my year did that. So it was a great grounding in the social science influences on health and medical care.
Yeah, absolutely.
Long time ago now. 1970s.
Okay, yeah. So okay, that's interesting that it was kind of an integrated degree. And obviously Trish is drawn on that background throughout her career. She's now Professor of Primary Care Health Science, but also co-director of the Interdisciplinary Research and Health Sciences Unit at the University of Oxford. Also point out that she has an Order of the British Empire, an OBE, which is a first for our webinar presenters. Although we did have Nick Black, but that was before his award. He presented a webinar.
Yeah, he's got a knighthood now, hasn't he?
That's right. Yeah, yes, but we couldn't claim that at the time of the webinar.
Nah.
So obviously there's lots of topics that Trish could have spoken about today, but together we selected Trish's more recent work on investigating the failure of technology projects in healthcare and the resulting NASS Framework. I'm assuming that's how it's pronounced.
That's how it's pronounced, yeah.
Yeah. So Trish's going to talk to us about that. Unfortunately, given the number of participants, we can't allow everyone to ask questions verbally, but there is a chat button, and so if you've got comments or questions, please feel free to type them into the chat function. I'll relay them to Trish at the end of the talk. So with that, I'll hand over to you, Trish. Thanks.
Great, thanks, Jonathan. So yes, this is about failed technology programs. Of course, most technology programs are not total failures, but they don't quite succeed in the way that we had hoped at the beginning. So really, this is also about partial successes or programs that don't go the direction you thought they were going to. And now I'm trying to move my slides on. Yeah, I've worked that out. So we call the framework the NASS Framework, and that stands for non-adoption, abandonment, and challenges to scale up, that is local scale up. You've got a program going, say, in one ward in a hospital, and you want to spread it to other departments in the hospital. Spread, meaning distance spread, you want the program, for example, to be picked up by other hospitals or healthcare organizations. And sustainability, which is the time dimension. Very easy to set up a program as a sort of demonstration of proof of concept, but you go back 2 years later and it's just fallen apart because somebody's left or because the context has changed. Now, you can see from this slide that we are also looking at the adoption of the technology. And initially I had called it the NASS Framework, but one of my postdocs had an 8-year-old and said it wouldn't be a very good idea to call it the NASS Framework. So we dropped the A and called it NASS. This slide shows how we developed the NASS Framework. We were looking particularly to explain why telehealth programs are so difficult to establish and sustain. But actually, a lot of the work we were doing was not about telehealth, it was about other technologies. And we got some funding from the Wellcome Trust for some case studies, which were really action research. We were trying to help a healthcare organization or a social care organization introduce a program of change with the aid of a particular technology. And we also had National Institute for Health Research funding to look at video consultations in healthcare. So we had a total of 6 case studies. We've now got a couple more which we added in. It's a rolling program of studying these quite big programs, and I think many of you will be doing similar kinds of work. Now, the secondary research on this slide consisted of me going away to Italy on a Rockefeller writing retreat where I had to sit in a villa for a month and do some desk research. And so I took all the literature I could find on the introduction of technology programs in healthcare. And I did a narrative systematic review. It was a wonderful, wonderful retreat. I took away some empirical data as well. And I came back from Italy about this time last year with this draft framework. And we then proceeded to apply the draft framework and hammer out the inconsistencies in it, try it out on more projects. Those of you who follow me on Twitter will know that I put out a tweet saying, does anyone want to test the draft NASS framework? And so we got about 20 teams around the world applying this framework to their case studies, and they came back saying, well, it doesn't work for us, or it needs a little bit of a tweak. And we refined it into the current NASS framework, which is actually continually evolving, because 2 weeks ago I presented this and we decided we needed to change it a little bit on the basis of some feedback someone gave me. So it is a bit of a perpetual beta version of the framework. So here it is. Just to talk you through the outline of it before I go into detail. The first dimension of the NASS framework is the condition, the illness, or the thing you're trying to address with the aid of the technology supported service. Then there's the technology. Then there's what we call the value proposition. Where does this technology generate value? And I'll go into that in more detail in a minute. Then there's the adopter system. In other words, the people who you would like to get involved in using the technology, including your clinical staff, your administrative staff, patient, and any caregivers who are going to be helping the patient use their bit of the technology. Then there's a big domain. The biggest domain of all in the NASS framework is the health or care organization. And you can see I've put organizations plural, because very often the technology is introduced in order to coordinate work across organizations and possibly even across sectors. So we try to solve the challenge, for example, of integrated care using the technology. What that means is more than one organization is having to put data in or use data in a shared technology, and that's not very easy. The sixth domain in the NASS framework is the wider system. That's mainly things like regulatory issues, national policy, what's happening in the industry, and so on. And then the reason why this framework looks like a caterpillar is that there is a time dimension. Domain 7 is the embedding and adaptation of the program and the technology over time. This is something that needs to evolve. And you can see that I deliberately made it look like an animal, because actually this is an organic thing. It's not a static thing. And that's going to be something I'm going to be talking about quite a lot over the next few minutes. Now, we need to think about complexity. Everything in life can be either simple, which means straightforward, predictable, few components, and I've used the example of making a sandwich, or complicated. That's kind of like making the sandwich. It's still predictable. It's still going to be a question of putting all the components together, as in building a rocket. Every time you build a rocket, if you follow the instructions, you're going to get the same rocket. Or complex. Now, a complex phenomenon follows a different logic. It is dynamic, it is unpredictable, and it's not easily disaggregated into constituent components. And I've used the example here of raising a child. You can raise one child according to one set of principles, but you apply the same principles to child number 2 and you don't get the same result. There are a lot of interdependencies in complex systems which play out differently every time they unfold. Now, almost everything in healthcare is in some way complex, but the problem with complexity is, as you can see, it's not very predictable. And so you can't manage things by algorithm or by standard operating procedure. You have to box and cox. So really the NASS framework is about identifying the complexities and interdependencies among and between the different domains, and then trying to work through those. And you can see that if it's a complex system, that there isn't going to be a set of rules or a formula that's going to bring you success every time. Okay, so complexity can occur in lots of different domains in the complex system, the clinical domain, the technical domain, etc., etc. And each of those domains can have different kinds of complexity. There can be structural or logistical complexity, which means aspects of things like scale, scope, pace, resources. You know, the more of that you have, the more complex it's going to be. There can be socio-political complexity in relation to things like goals, conflicts of interest, and then there can be emergent complexity, which is all about how the baseline, the context changes over time, and things like scope creep. Now, all those things are happening in a lot of different domains in almost every technology-supported project or program. So let's now start to unpack those. The first domain is the condition or the illness. So there's the condition itself, and then there's comorbidities and sociocultural factors. As an example of a simple condition, I've given you a broken ankle. Every time someone has a broken ankle, you do the X-ray, and the management is pretty similar depending on which bone is broken. A complicated condition might be cancer. Again, once you've characterized the cancer, there's a much more complicated algorithm, but really you can manage that cancer according to the algorithm. But something like dementia, or maybe mental health problems, drug and alcohol, etc., is a complex condition. Those conditions are poorly characterized, they're unpredictable. Perhaps there's a high risk element. One of the examples we had in our case studies was diabetes in pregnancy, where you've got two patients, where you've got, on the one hand, you want the mother to be well throughout the pregnancy. On the other hand, you've also got the fetus. And if the mother's diabetes is poorly controlled, then that puts the fetus at huge risk of fetal abnormality and fetal death. So that immediately puts the condition into complex. The other thing that we found with diabetes in pregnancy is that, particularly with gestational diabetes, many of the patients are from poor, socially excluded groups, ethnic minority groups, immigrants, people with uncertain citizenship status, and so on and so on. And those kind of things pose major challenges to care planning and services. For example, you have to have an interpreter in the room every time you see the patient, that kind of thing. So that's the condition. Now, the interesting thing about the literature review that I did when I was in Italy, no previous framework for looking at the introduction of technologies had addressed the complexity of the underlying condition. And what we had was many examples of technologies that had been designed for a textbook case of, for example, heart failure or diabetes or dementia or whatever. And they hadn't taken account of the fact that most of the patients didn't look like the patient in the textbook. So as a clinician, it was very evident to me, I mean, I'm a GP, it was very evident to me in the cases we were looking at that the condition itself was a huge determinant of the complexity and therefore the success of the program. For example, a telehealth program for diabetes and pregnancy in the very deprived part of London where we were studying this particular condition, out of 500 potentially eligible patients, in other words, the denominator population of the diabetic clinic or the antenatal diabetic clinic, only 11 were considered safe, in other words, clinically eligible to do remote consulting. 11 out of 500, and that was just because of the complexity of the condition. The second domain of the NASS framework is the technology itself, and that has 5 domains: the material properties, the knowledge needed to use it, the knowledge that it generates, the technology supply model, and the question of who owns the intellectual property. You go through these. The material features of the technology, if it's simple or complicated, it already exists. You can walk into a shop and buy one. It's dependable, like the telephone, for example, or a pendant alarm is pretty dependable. You press the button and someone answers. And it's already fully interoperable with the current system. But in many cases, the technology hasn't yet been developed. The contractor or the commercial supplier will come along and say, we will develop this technology and then we'll make it interoperable. But it hasn't yet happened. And so you have to factor that uncertainty in. The knowledge needed to use the technology is pretty straightforward. The less you need, the more simple it is. And then this question of what kind of knowledge does the technology bring into play? Now, we had an example of telehealth for heart failure, where the patient would sit at home and they would put their finger in the hole and take various readings, their blood pressure, their blood oxygen level, the pulse rate, pulse rhythm, all that kind of thing. And that data would be transmitted to a central monitoring centre where there would be a nurse looking at the data, which was a sort of aggregate of various readings over the previous few days. The problem was that with some of the heart failure nurses, what they'd been doing before was going and visiting people in their homes, and they'd been squeezing the patient's ankles to see how swollen the feet were. And that skin-to-skin contact between the nurse and the patient, saying, I can see that your legs are a bit more swollen, therefore your heart failure is obviously worse. That was data that they trusted and made them feel pretty confident in assessing. For example, if there was no ankle edema, the nurse was pretty confident that the heart failure was well controlled. Whereas these figures coming through on a graph, if you like, or as raw numbers, was not the kind of data that the nurse could trust 100%. They also had to phone up the patient and say, are your ankles swollen, that kind of thing. And so I use that as an example of the technology makes some information visible, but it also puts some information in the background, or it says you've got to look at this data instead of the data that you would normally have used as a clinician. And whether or not the clinician trusts and is confident in that data is pretty crucial influence on whether the clinician is going to actually use it. Technology supply model. If the technology is generic, plug and play, customizable off the shelf, these kind of things, if it's easily substituted, so one manufacturer goes out of business, you can go and buy it from someone else. That's all very simple, but actually very often the manufacturer is tying you into a particular relationship, and if they go out of business, you're then up the creek without a paddle because it's hard to substitute. Then there's the question of who owns the IP. This is one that isn't in the paper because we added it afterwards. The technology that is a sort of algorithmic software that is trained on a set of healthcare data, the manufacturer may say, well, we own the IP of the algorithm and we'll sell it back to you. And of course, in the UK, the healthcare people aren't very happy with that. They say, well, wait a minute, this is National Health Service data. So there's a lot of argument about algorithmic programs, machine learning, where the National Health Service is not prepared to buy into these, no matter how good the algorithms, unless they have the right kind of IP sharing. And that's something that holds things up quite a lot. Let me talk to you about the value proposition. The two kinds of value: supply side value, which is the value to the developer of the technology, and then there's demand side value, the value to the patient and actually to the healthcare system. So in supply side value, this is all about the business case. When you're a clinical entrepreneur developing a technology, you want to make sure that the people investing in that have got a reasonable chance of return on investment. And if your business case rests on questionable assumptions and is a high risk to investors, you probably won't even get the startup money. Same thing if you're writing a grant application for publicly funded R&D. And then there's the demand side value. The question which so many people forget to ask: is this technology actually desirable for patients? Is it going to help people? Is there what Everett Rogers would have called a relative advantage? And then there's also questions about safety and cost effectiveness. This is your standard health technology assessment stuff. We all have to do it if we're introducing a medical device or drug or whatever. I've given you two examples here. The first example, you're looking at that brightly coloured thing on the left-hand side, that's actually a picture of someone's liver taken with a very fancy imaging device. And this is a colleague of mine in Oxford who's developed what he calls a non-invasive liver biopsy to monitor people with liver disease, instead of having to have a needle stuck in them every 3 months or so. And you can see it's a very pretty picture, but the detail of that imaging is so good that it saves patients the quite high risk liver biopsy procedure, which is not a very nice thing to have done, especially when you've got liver disease and you might bleed afterwards. So my colleague in Oxford has successfully established this because he had a very good business case and because it was highly desirable, it was safe, it was cost effective, it stopped people having to be admitted to hospital. Wonderful. The picture on the right is a robotic wheelchair. I think the gentleman sitting in it is fine from the waist up. Why would he need a robot? He can control his wheelchair without any kind of robotics. And so this turned out to be an extremely expensive wheelchair that nobody really wanted. The patients were perfectly happy with an ordinary wheelchair, and the manufacturer didn't make any money out of that, and I think went out of business. Let me talk to you about adopters. The technology needs to be used by people, staff, patients, carers. So the simple situation is where the staff member doesn't need to learn anything new, doesn't need to adopt a new role, you don't need to hire anyone to use it. In a more complex situation, there's either a threat to people's jobs or there's a big change in their scope of practice. And the heart failure example, where the heart failure nurses were going to have to change from driving around the region, visiting people in their homes, doing quite traditional nursing work, to sitting in an office looking at streams of data. That's a big change to the scope of practice, and actually also implies a change in professional identity. And some sites where we were looking at this multi-site heart failure initiative, some of the community-based heart failure nurses simply refused to get involved in it. In other sites, they were very keen and very enthusiastic. And so we then asked questions about what had happened in the past to influence those attitudes. Then there's the question of what is expected of the patient, or perhaps if they're demented, the primary carer. And again, I've given you an example at the bottom of an implantable device where the patient doesn't have to do anything, the data gets collected automatically. But of course, if the patient is expected to do something complex, such as make a judgment of what is an emergency, or to adjust their own treatment in relation to what the device is telling them, that actually introduces more complexity. And then there's what is assumed about the wider network of carers. One of our case examples was a GPS monitoring system for patients with dementia who tend to like to go out walking and they get lost. And so the idea was that we give them a wristwatch which had a GPS device, and when they didn't come home for tea, we could then, find out where they were and go and look for them. The problem was that we had very, very few families that had enough family members able and willing to go and look for Grandad when he didn't come back, even when the monitoring centre said, well, this is where we found him. It wasn't just a question of who was willing to go out. It was also the question of those family members coordinating among themselves and coordinating with the call centre. So, and of course, this is an interesting example of social determinants, because there's lots of evidence that people who live in poverty, people who are, for example, asylum seekers, etc., have very, very weak social networks. They don't have the family members and the neighbours and things that someone who is, for example, educated middle class has. So that was all patterning. And in fact, the GPS monitoring device, we had a denominator population of around 1,500 people in the district who were potentially eligible for this dementia monitoring device, and only 11 ever signed up for it. Only 7 agreed to be in the research, and by the end of the research, only 3 of them were still using the device. And a lot of that was about whether or not the patient was able to keep the wristwatch on, and some demented people just took it off, and also the extent of the care network. The organizational dimension has a number of different subdomains, and I'll go through these one by one. The first one is the organization's capacity to innovate in anything. And there's a lot of work done. I did a piece of work back in 2004 that summarized this. Some organizations are capable of adopting innovations and mainstreaming them within that organization. And they are characterized by good leadership, flat hierarchies, semi-autonomous teams within the organization that can make their own decisions. Slack resources means there's a bit of drawdown budget to put into new projects, for example, to send staff on training courses, backfill them, that kind of thing. And also where risk-taking is encouraged. If you take a risk and you fail, you don't then get fired or get punished. You get, encouraged to learn from the mistake. And then there's the question of how ready the organization is for this particular technology-supported change, what we call innovation system fit. And also the tension for change. If there is high tension for change, everybody is fed up with the current situation and wants something new. Of course, if people are perfectly happy with things as they are, that's much more difficult. Then there's also the question of whether the supporters of the innovation outnumber the opponents, and whether there's an opponent sitting on the board with a right of veto and what we call wrecking power. The question of the funding decision came up in a number of our cases, particularly the cases around integrated care. So we had one example of a data warehouse which was shared between primary and secondary and social care in one borough of London. That required multiple organisations to enter into partnership agreements in a situation where people in organisation A were having to put data into the technology, and people in organisation B were going to save time and money as a result of that activity. With the data warehouse example, there were anticipated down the line cost savings, which would then somehow be distributed through the participating organisations. But at the time of drawing up contracts, it wasn't known how much savings would actually occur. The question of how much new infrastructure, how many new members of staff were to be appointed, and often those staff are appointed across organisations, so there's an awful lot of argy-bargying about who's going to pay the money up front. It's a lot easier if those organisations already have a partnership agreement, preferably some existing subcontracts. And that sometimes happens, but when it doesn't, it's all a bit more complex. Implications for team routines. This again is pretty obvious and easy once you think about it. But let me give you an example. In the video consultation project that we were doing, so people were moving from, there was one hospital moving from traditional outpatient appointments to running those appointments by Skype. Now, you'd think that would be pretty straightforward, just install Skype on the computer and the clinician goes ahead and Skypes the patient. But of course, there was all sorts of things like the virtual waiting room where the patient, how do you know the patient has arrived, in inverted commas, when they're just sitting at home? You know, what happens in an ordinary outpatient appointment is that the patient actually walks up to the desk and says, I am here. So booking those patients in, and also at the end of the consultation, completing the paperwork, making sure that the records were filled out and returned to the records room when we're talking about paper records. That was all incredibly complicated, and we had some consultants say, look, I'm not doing this because I'm not being the records clerk. I don't mind Skyping the patient, but I'm not running around doing my own records. So big changes to team routines. And we're still going about 4 or 5 years later with some consultants just not wanting to do it because it's such a disruption of their routine. Then there's the work needed to implement the technology and the change within the organisation. And this is Carl May's normalisation process theory. You need to do a lot of work to build a vision, to persuade people that this change is something that is good for the organisation and good for the patients. And then you also need the actual work of implementation to develop new practices and to evaluate the progress. Not so long ago, one of the hospitals that I am involved in spent £6 million on new technology. They had £6 million as a grant to introduce new technology, and they spent the whole of the money on the technology, didn't retain any of the budget for the implementation or evaluation. You can hardly believe that that amount of money could be spent without regard to the work of implementation. It's a cost, it's a budget line, and it's always, so not always, but very often, people underestimate that work and that cost. The sixth domain is the wider system. Let me show you this. It's straightforward conceptually, but again, very often these aspects of the wider system are really complex and they become a block to progress. The policy context, that's probably straightforward. Regulatory and legal hurdles, particularly around information governance, security, can stymie an otherwise successful project. We've got one at the moment with the video outpatient consultation program. We're working at national level with the people who set the tariff for a video consultation. But there is no national tariff for the video consultation. You can have a tariff for a face-to-face outpatient consultation and a tariff for a phone call, but at the moment there is no official tariff for a video consultation. People do local workarounds, they arrange it locally, but it would be a lot easier if there was a national tariff. Why isn't there a national tariff? Because the health economists say they haven't got good enough data on how much it costs to deliver a video consultation. And so we're working with them on that. Again, professional bodies and citizens, if you've got a following wind, that's going to be great, but sometimes you don't have. The final domain of the NASS framework is embedding and adapting over time. And there's two subdomains here. One is about the scope built into the technology and the project and the service model for adaptation. If what you've got is a static technology that you cannot adapt, you cannot change it, you can't move it to a new platform, you can't add any more features, that technology is not going to last very long. You know, Moore's law says it's going to last for 18 months. On the other hand, if you built into your technology the scope for adaptation and also in the service model, then it will last longer. And then there's this wonderful work by Jeff Braithwaite's team down in Melbourne, Sydney, I think, sorry, in Australia, on organisational resilience. And you can see from the pictures here, I'm talking about resilience to external shocks, external setbacks. To what extent can the organization make sense of big external changes and adapt in a way that weathers those storms? In the UK, we've got Brexit coming, for example, which brings big changes to the regulatory framework for medical devices, for example. To what extent are organizations able to cope with that? And a lot of that is about the extent, again, it's back to leadership and adaptation of organizational processes to accommodate. Okay, so here's the NASS framework in all its glory. I'm sure there's other aspects that we need to bring in. Here's the NASS hypothesis. If everything is simple, the program's going to be relatively easy to adopt, it's going to spread easily, it's going to be sustained. But that is almost never the case. If several domains are complicated, your program will still happen, but it's going to be more difficult, it's going to be more expensive, and it's going to be slower to get up on board. But if several domains are complex, it's going to be almost impossible to achieve sustained and widespread adoption of the program, and particularly to sustain it over time. So what do we do with this framework, apart from write academic papers about it? Well, these are the things that are being done with the NASS framework. We only published it 3 months ago. It's being used already to inform the design of technologies, particularly in a more simple way, perhaps fewer bells and whistles. It's beginning to be used. NHS Digital, which is the sort of purchasing arm of the NHS, have begun to pilot the use of the NASS framework to reject potential technology solutions that probably have limited chance of success. So they're using it in a due diligence way, although that work is very early at the moment. Use it to explain failure, of course, and learn from them. I have developed what's called a complexity assessment tool based on the NASS framework, which allows teams to identify, understand, perhaps reduce, and manage complexity in new and emerging programs. So if we go through the complexity assessment tool, reduce complexity where we can, and where we can't, we run with it. And maybe other ideas, I'd love to hear from you on how else you might use the NASS framework. So here's the in-progress work with the NASS complexity assessment tool. As I've said, this is a way of teasing out the uncertainties and interdependencies by developing a rich narrative of the technology and the project or program that you want to use it for. To try to limit the scale and scope and the interdependencies, and maybe slow the pace of the program. And then these are the ways that we might run with complexity. Perhaps we need to strengthen leadership, perhaps we need to strengthen the vision, developing individuals, building relationships, putting Slack resources available for local teams to use however they want to achieve the goal. Building relationships, very, very important, managing conflict, controlling scope creep, and also improving the policy and regulatory context so that sixth domain, the wider system, isn't quite so difficult to work through. So thank you for your attention. That's as far as we've got with the NASS framework. I'd be very interested in your questions and comments and hopefully your tweets. So I'll hand back to Jonathan now.